Good morning, everyone. My name is Michael Myers. I'm one of the members of the planning committee for this Downstate Celebratory conference, and I'm delighted to welcome you all here this morning. But before we begin our conference, I want to let you know some sad news. Dr. Carl Cohen, who was a distinguished service professor here at SUNY Downstate and former director, co-director of our division of geriatric psychiatry, died about 10 days ago on April the 27th. The tributes have been pouring in. There's been a memorial. I'll just read to you what I posted on LinkedIn, which is really just loaded with tributes. I wrote this: Dr. Cohen's death is a huge loss for our department and psychiatry at large. Carl was a mentor to many, so gracious with his time, always curious, and dedicated to fairness. What a role model. He will be missed. Please join me in a moment of silence. Thank you. The other person I wanted to mention was Dr. Herb Pardes, who also died within the last 10 days. Dr. Pardes was a graduate of Downstate, our medical school, Kings County residency. He was a national luminary in psychiatry. So many people knew him. The one nice thing that I wanted to just share with you was that I sent him an invitation to this, because even though I was told that he obviously wouldn't be able to attend, he was in a care home, but that he would be able to read, and I think he would have been so proud that we were having this celebratory conference. So I wanted to just convey that to you. The other announcement I wanted to make is Dr. Vora, who is one of our speakers after the break, has to leave early today, so that's the only change in the schedule. She'll be going just ahead of Dr. Schooler, who is currently scheduled to be the first one. So with those remarks, I wanted to just introduce our Dean, Dr. Brunicardi, Senior Vice President and Dean, College of Medicine, Professor of Surgery, SUNY Downstate, and I would like to invite him to just give some opening remarks. Thank you, Chuck.
Thank you, Michael. It's a pleasure to be here this morning. Good morning. Dr. Viswanathan and Dr. Viswanathan, welcome and congratulations. So welcome everyone to this celebratory conference where we're honoring Dr. Ramaswamy Viswanathan and celebrating Downstate's Department of Psychiatry and Behavioral Sciences' long history of being a nationally renowned educational system, a provider of outstanding clinical services to our community, and a continuous source of top-notch scientific research, one of the strongest research departments in the College of Medicine. And this month, Dr. Viswanathan, or Dr. Vis, as we all know him, begins his term as the president of the American Psychiatric Association. The APA is the world's largest psychiatric association and has more than 37,000 members. It's phenomenal. And is the main body of psychiatry in the United States. Dr. Vis is the first person from Brooklyn in Downstate's history to be elected to this position, and is also the third person of color to be elected president since the organization's inception in 1844, nearly 180 years ago. Election to this important leadership role in the premier professional psychiatric organization is a reflection of how respected Dr. Vis is on the national and international stage. Congratulations, Dr. Vis. We look forward to seeing the wonderful accomplishments as the president of the APA. This is also a perfect opportunity to showcase our Department of Psychiatry and Behavioral Sciences' cutting-edge scientific research, comprehensive clinical services, and nationally recognized training programs at Downstate. Several alumni and other invited speakers are here to give presentations ranging from bench to bedside and how this benefits our community. So I look forward to hearing today's presentations. So thank you.
Thank you, Dr. Brunicardi. I'd also like to invite Dr. Camille Clare to the podium. She is professor and chair of the Department of Obstetrics and Gynecology, professor of health policy and management, Downstate School of Public Health, SUNY Downstate Health Sciences University, secretary of the American College of Obstetrics and Gynecology. Dr. Clare.
Okay, forgive me as I fumble to find slides as my colleague will help me bring them up. Dr. Myers asked me to just make some opening remarks, and then someone said, bring your USB for slides. So as I quickly put together a slide set, but it's mostly, I'm gonna be doing mostly talking because the slides are just, yes, this one. Thank you, are just an additive. So thanks to Dr. Myers, President Riley, Dean Brunicardi, Dr. Viss, fellow colleagues and friends. You already heard a little bit about who I am. I am also most primarily a practicing obstetrician gynecologist here in Central Brooklyn. And as mentioned, I've been an active member of my specialty society, which is called the American College of Obstetricians and Gynecologists. Very often confused, not the specialty, we're made of people. And I've been involved since I was an intern, actually. And just a brief story, how I got to go to my first meeting as an intern. I'm not even sure how I got that happen, but nobody else wanted to go. So I'm like, I'll go. And then really the rest is history. So I'm not really representing ACOG as an organization. I'm representing a member, but what I've been asked to speak about a little bit is what Dr. Myers asked me actually to speak about was how important it is to reach out in liaison with colleagues and committees outside of your home institution. But I took it to mean to speak about what it means to be a leader in your medical specialty society. So let's see how I can coordinate. So that's what I'm going to do. I'm going to talk a little bit about what I learned about Dr. Viss from Dr. Myers. Obviously, he knows himself better than I do. I'm going to talk about what does psychiatry and obstetrics and gynecology, and I'll call it OBGYN because we do by convention, what is that connection, and what's the importance of collaboration and a connection outside of your home institution. So let's start with what I learned about Dr. Viss. Now let me see if I can find it, because I made my paperwork really, really big so I can see. So in the 1990s, I learned Dr. Viss represented the minority and underrepresented groups in the American Psychiatric Association, and he's continually to hold office in the APA since that time, serving on countless committees, work groups, councils, and the Board of Trustees. And then obviously he was elected as president-elect in 2023 and began his term as president at the end of his annual meeting yesterday. And he's also previously simultaneously held offices both in the Brooklyn Psychiatric Society and the New York State Psychiatric Association. So he's a hard-working psychiatrist. That's what I took from that. So what about the psychiatry and OBGYN connection? So first, from my reading, at least since at least 2009, the APA and the American College of Obstetricians and Gynecologists, which is called ACOG, have collaborated on issues pertaining to depression in pregnant persons, especially led by the work of a notable colleague such as Dr. Kimberly Yonkers. Secondly, mental health conditions, including substance use disorder, is among the leading causes of maternal mortality and morbidity throughout the United States, and especially in New York City and New York State. So I can tell you fresh off the press, the 2018 recommendations of the New York State Maternal Mortality Review Board, which I do sit on the review board for the city as well, just published that in recommendations a few weeks ago. So So this is just really what it looks like, the data. So for non-Hispanic white individuals, you can see the mental health conditions is the number, right at the top, compared to non-Hispanic black individuals where there are other causes, cardiomyopathy, preeclampsia, bleeding, and things like that. So that's really important to know. So what about the importance of collaboration and connection outside of your home institution? So I'd like to talk about three things: mentorship, professional development, and advocacy. So, and I have no disclosures. I don't know if this is a CME talk, but I should have said that. So in terms of mentorship, I've been mentored, and I've been a mentor to many within ACOG, because really what I've learned from being involved in my specialty society is that it's really important to connect with future leaders, give you the skills to develop you into a leader, especially with consistency of participation, just like I mentioned with Dr. Vis. And I told you myself, I've been an active member in my specialty society since I was an intern, every single year, and that's a long time ago, but we don't do numbers here, so I didn't put the year in. It also allows you to be exposed to aspects of your field that you might not have otherwise had. So subspecialists that are not in your training program, that are not available to your institution. It gives you an opportunity to meet individuals that you may meet that could be your external letter writers for promotion, especially those of you that are faculty members. That's really, really important. Or for letters of recommendation for residencies, for students in the room. I can't tell who's anymore, and also for fellowship and for job opportunities. So that's really, really critical. In terms of professional development, it allows you an opportunity for leadership coaching. I myself did a leadership program as part of ACOG when I was it was called Young Physician on the board back many years ago. It also prepares you for leadership. It exposes to role models and shows you what role modeling looks like. It allows you to work on committees. I was involved in many national committees even as a resident. And you really learn how the sausage is made, so to speak, for me in obstetrics and gynecology, for you in psychiatry. And most importantly, for me in particular, in my specialty, advocacy. I learned how to lobby with ACOG. I continue to lobby, not only for the profession, for my patients, for the House of Medicine, and really learned about collaboration and sometimes compromise. So I'm going to share with you some examples on the advocacy and collaboration front. So the APA and ACOG are among, let me see if I can advance probably, there we go, are among the 6 total members of the group of 6 medical societies that work together, including things on advocacy and collaboration on issues pertinent to physicians and the patients we collectively serve. So in addition to the APA and ACOG, also includes the American College of Physicians, which President Riley is President Emeritus. I didn't get in advance the president that Dr. Brunicardi was president of. He'll let me know, but he was president of a surgical society as well. He'll tell us, or you ask him separately. So he's also been a president of a society. The American Academy of Family Physicians is a member of the group of 6, as well as the American Academy of Pediatrics and the American Osteopathic Association. So our collective organizations represent more than 560,000 members, and you can Google it, www.groupof6.org. In addition, we were among the 75 healthcare organizations to release a joint statement in opposition to legislative interference in 2022, especially as we're approaching almost 2 years of the unfortunate post-Roe era that we're a part of. So I would be remiss if I didn't spend some time speaking about my beloved specialty, obstetrics and gynecology, and my specialty organization, the American College of Obstetricians and Gynecologists, often confused for obstetrics and gynecology. But as I said, we're made up of people, and so that's where the name comes from. So ACOG was founded in 1951. A mere baby compared to APA, founded in 1844, and I love an OB metaphor, so I'm going to say them often when I can. And we represent approximately 61,000 obstetricians and gynecologists in the United States and abroad, many countries, societies, areas in North and South America. So in my opinion, we are the best specialty since sliced bread. which is accurate because sliced bread was invented in 1928 by Otto Frederick Rottweiler from Des Moines, Iowa. And another connection between psychiatrists and OBGYNs is that our immediate past president, Dr. Ifat Hoskins, who was a mentor of mine, is a mentor of mine. As her presidential initiative, she had mental health as her presidential initiative, and she is actually duly trained as a psychiatrist, an obstetrician gynecologist, and she's a maternal fetal medicine specialist. And my own personal interest is that my clinical and my research interests are in perinatal mood and anxiety disorders. And I will be the site PI for a $3.6 million grant, 6-year grant that we obtained from the PCORI to investigate equity in perinatal mental health, especially as we think about what we're doing in obstetrical clinics. So thank you. Thank you. But this is not about me. This is about Dr. Vis. So, Dr. Vis, we're excited about your leadership, your continued commitment to your patients, to the specialty of psychiatry, and to what your highest ascent to the level of president of the APA means to the Downstate family and the community of Central Brooklyn and beyond. But I do have a personal charge for you to consider during your term. So please consider to continue to focus on perinatal mental health. It is a critical component of the total health of birthing and pregnant persons and their families. I learned your wife is a pediatrician, so we are constantly joined at the cord, so to speak. I also implore you to consider the expansion of the behavioral health workforce, including psychiatrists and psychologists, which is paramount to the success of mental health services, which continues to be a challenge for many of the patients we serve. Also, thinking about expansion of reproductive psychiatry subspecialty fellowships. I hope some of your psychiatric residents, Dr. Scott will let me know that their interest in that in the field, and also the training of general psychiatrists, as these areas are important to all of our patients and the aspects of medicine and the impact of all of us and our families. So, Dr. Vis, best of luck, and we remain committed to serve you as APA president and beyond here at Downstate. So thank you so much.
Dr. Clare, you're a tough act to follow. Oh my gosh, that was so wonderful. Thank you. Thank you so much. I learned a lot about you, actually, in the work that you do, and that, thank you. Even though it's about Dr. Vis, as you say. So next on the agenda is the introduction of Dr. Vis by me. Okay, so you've already heard a little bit about him, but there's a lot more. We've just finished the American Psychiatric Association. I had the honor of introducing Dr. Vis at the opening ceremonies, but I only had 2 minutes. And so because I've been one of the chairs of this planning committee, I've given myself more than 2 minutes to tell you. The Dean and Dr. Clare have already mentioned things that I won't repeat. But let me tell you this. He was born in India. He was a prize-winning medical student at Madras Medical College. And after graduating, he immigrated to the United States and began residency training here in New York City, in Brooklyn. He is board certified. I love saying this. There's such a list of these, so pay attention. He's board certified in psychiatry, of course, internal medicine, geriatric psychiatry, forensic psychiatry, addiction psychiatry, and consultation liaison psychiatry. So he's a tenured professor in our Department of Psychiatry, and he is our interim chair. Yes, that's right. And also as a fellowship in sex therapy. Thank you. Thank you, Dr. Frieda. He's been an attending physician here since completing his residency. As well as he's been the director of the Consultation Liaison Service here, director of education across the street for the CL service at Kings County. And currently, he's the founder and program director of the Consultation Liaison Psychiatry Fellowship, which started in 2021. And at the medical school level, he's one of our current senators until 2025. SUNY Faculty Senate, one of 4 senators from our campus in the 64 campus body. He's been a presiding officer, faculty and professional staff of the College of Medicine. I mean, everybody knows him because I don't think he ever says no to any sort of either invitation or an opportunity. He's currently co-chair of the Faculty Wellness Work Group. He's co-chair of the Student Health and Wellness Work Group here at Downstate. And also, I wanted to going through his CV was really a wonderful experience. He has a huge number of publications in book chapters, both peer-reviewed and non-peer-reviewed. But what is distinctive is that the vast majority of his articles, are co-written with trainees, medical students, residents, and fellows. A huge, huge number. Then he has a mentorship list in his CV, and that runs for pages. And it's no surprise then that I'm going to come to his awards in just a moment, that he would have such a wide range of awards. His reach in psychiatry, as Dr. Clare mentioned, is both here in Brooklyn, the Brooklyn site. By the way, he holds membership on all of these things. He doesn't just sort of join and then you've got this long list. So that's the Brooklyn Psychiatric Society, the New York State Psychiatric Association, of course, the National American Psychiatric Association, the Group for the Advancement of Psychiatry, which is a think tank organization in this country, Indo-American Psychiatric Association, the American Medical Association, again holding office, the Academy of CL Psychiatry, the American Academy of Psychiatry and the Law, and now the World Psychiatric Association. I want to talk a little bit about his service because he just runs to the problem. COVID-19, I'll never forget that weekend. I think it might even before Governor Cuomo designated UHB a COVID-only center, I got a call from him and from Lauren that we're setting up support services for everyone here at Downstate. And Lauren put this whole platform together, but that's what I mean. He really realized we're onto something very serious here. Our frontline people, especially in emergency medicine, and also our intensivists and our trainees are going to need support. His work in diversity and inclusion goes back even before we had that language. I can remember that so well in the assembly. That's when I first met him. Advocacy for our patients in psychiatry that is local, it's state, it's national. He's worked with national legislators as well. In January, I'll never forget this, January 2010, immediately after the Haiti earthquake, the next thing you know, we were assembled at a church here and also, again, putting out services. Before I came here, this had been involved in 9/11 screening and counseling services. It's that sort of thing that exists outside the so-called ivory tower. One thing I love from his CV is the number of published letters to the editor of the New York Times. As somebody who's I've managed to get a couple of my 3 or 4 dozen letters submitted, published. I think I counted 5, but I think there are more. If you really go through his CV with a fine-tooth comb, it's probably 7 or 8, including one called Strom Thurmond's Daughter, which I thought was really interesting. So I won't go on and on, but I have to tell you just about some of his more recent awards, and then he's going to talk about the history of psychiatry here at Downstate. So just last year, he got a Lifetime Achievement Award here in New York City. That's a national thing for consultation liaisons, the Society for Liaison Psychiatry. I was privileged to be in the audience. In 2022, he got the APA Assembly Resident Fellow Mentor Award. So again, national stage. Induction into Alpha Omega Alpha Honor Society, Medical Society here at Downstate as a faculty member. In 2019, through the APA, he got the Irma Bland Award for Excellence in Psychiatry Residency Education. No surprise that about 20 years ago, he got the Nancy Reske Award. That's for medical student teaching. In 2018 here, he got the Chancellor's Award for Excellence in Faculty Service. In 2017, the Faculty Award for Commitment to Excellence in Graduate Medical Education, presented by President Riley in May of 2017. And there's just two more of this long list that I wanted to mention. One was because I have a long history in the APA Assembly as well, the Ron Shello Award for Outstanding Service to the APA Assembly, in which he served for many, many years. And this one, which is so important, the George Tarzan Award. If I remember correctly, I think Dr. Tarzan was our first IMG president of the APA. And Dr. Vis got the George Tarzan Award for Outstanding Contribution to the integration of IMGs, international medical graduates, into American psychiatry. And he's well known for that across the nation. So with that little introduction, please welcome Dr. Vis, who's going to talk about the history of psychiatry.
Thank you, Dr. Myers, for that warm introduction. I want, first of all, I would like to extend a special thanks to Lauren and Barbara and the team. I know they cannot hear us, but they have really put in tremendous effort in not only in organizing this meeting. Actually, we are really fortunate to have staff like that in our department, and that's one of the main strengths of our department, why our department has been doing so well. I also thank Dean Brunicardi and Dr. Clare and other speakers here who will follow for taking the effort to come here in spite of your busy schedule and kind of recognize our department and all of you for participating in this event. Before going on to the history of psychiatry, just a couple of things about my presidency. Every president of the APA chooses a theme and for the annual meeting as well as for a lot of work during his or her term. I have chosen the theme Lifestyle for Positive Mental and Physical Health. And because many of the things like the perinatal mortality rate, Dr. Clare mentioned, and many of the morbidity, both in physical and mental health, are attributable to some lifestyle factors. In fact, 80% of our healthcare spending is spent on illnesses which are attributable to lifestyle factors. And social determinants of health play a huge role. Poor people, people in many neighborhoods do not have access to healthy food options. The supermarkets don't stock them. They do not have access to exercise, and too much noise interferes with their sleep. So these are all the things which we need to attend to. And also at an individual level, we need to take action. A lot more can be practiced by ourselves in terms of paying attention to the 6 pillars, exercise, both aerobic as well as weightlifting, nutrition, restorative sleep, social connectedness, dealing with stress, stress reduction, and also avoidance of harmful substances. So these all can have a major impact. And at the same time, they are very scientific. There are a lot of advanced research. For example, patients with schizophrenia who have reduced the hippocampal volume, there are studies done which show 3 months of aerobic exercise results in increase in hippocampal volume. This is demonstrated by neuroimaging, and this is accompanied by improvement in their symptoms, in what's called negative symptoms and cognitive functioning. And the good news is they had a normal control who exercised. That again resulted in increase in hippocampal volume and better cognitive functioning. And there's a lot of potential for prevention or delay of the onset of dementia. And also exercise is as effective as SSRIs in moderate depression. And the exercise doesn't work simply by better cardiovascular fitness, even though that's an important aspect. But the skeletal muscle actually secretes a brain-derived neurotrophic factor. And also there are a lot of anti-inflammatory effects. The same thing can be said about nutrition. There are specific foods. The whole idea is you have to eat really healthy food, which should be quite diverse. Variety is important. But some of the interesting things is there was a study done called PREDIMED study in Spain, where people who are already on a Mediterranean diet, they gave them an extra ounce of nuts every day, and that cut the stroke reduction by half. This is a prospective study. And there are also epidemiologic studies showing people who eat nuts every day, their mortality is reduced by 15%. And also, there's plenty of evidence for beans, lentils, cruciferous vegetables. So there's a lot of science to it. And people also have mapped out the specific mechanisms by which they help with both mental illness. Also, people who are depressed, if they eat nuts, their depression improves. So it's important for both mental and physical health. So I hope you all will pay attention to your own health, and also whatever you do, psychotherapy, medication, also pay attention to their lifestyle factors as well as social determinants of health. Okay, now let me tell you about the history of our department is quite complex. So then all of you know Downstate was Long Island College of Medicine from the mid-19th century. And if you walk down near the library, there is a portrait of Alfred Adler. All of you know, right? He was the founder of what's called the second school of psychiatry. He was a colleague of Freud, but then he separated from him and formed his own school called Individual Psychology, world-famous person, so I'm proud that he was on our faculty, right? You cannot beat that. And SUNY Downstate era began in 1950. I think the basic science building went up in the early 50s. And the hospital building went up, I think, in 1966. And so the medical school moved from Long Island College Hospital to this site. And ever since the founding of our department, Kings County Hospital has been the major affiliate, even though it's affiliate, it's the major teaching center for our residents and students. So that has been always been the main hospital. I'm happy that Dr. Ananthamoorthy is here. She will tell you more about the excellent services they are doing for our patients and the community. And so one of the pioneers in psychopharmacology was Dr. David Engelhardt. I had the privilege of working with him when I began my residency, and cutting-edge research on antipsychotic medications. And so it so happened that Dr. Nina Schooler, she was at NIMH at that time, and so she also worked closely with Dr. Engelhardt at Kings County Hospital, and she will tell you more about how helpful he was in her professional development. We actually held a Engelhardt commemorative symposium in, I think, 2000. It's on the top. Doesn't show up. Okay. I think 2000, in the year 2003, all day. Sadly, we cannot find a photograph of Dr. Engelhardt. The internet doesn't show up, and even Dr. Schooler couldn't find it. But these were the speakers in that conference. And of course, Dr. Schooler, I'm happy that she has been our faculty. You will again hear later from her. We don't know who was the chair before Dr. Herbert Pardes. So even the people who were here in the late 60s, they don't remember. And so Herbert Pardes was, as Dr. Myers mentioned, he was a student of Downstate, trained at Downstate, and went on to have really national and international fame. And then he left to become a chair at Colorado, and then from there he moved to NIMH. And Dr. Dickey's was the interim chair. He was a psychoanalyst. And Melvin Schaffman was the residency program director, for those of you, residents here. At that time, I trained during that time. The program was strongly psychoanalytic, and we learned a lot of insight-directed therapy. And we also were fortunate that a psychoanalytic institute was on premises. And it was mainly based in Kings County Hospital. Even though it's a city hospital, it was very interesting. But the hospital mainly deals with very severely ill people. But we had psychoanalysts teaching them. Even in the emergency room, when I'm getting a supervision, it was psychoanalytically oriented. We had excellent supervision. We had plenty of faculty at that time. And they would spend, really, for an hour we spent with the patient evaluating the emergency room. Right in the emergency room, they would spend about half an hour or 45 minutes discussing it from a psychoanalytic point of view. And the same was true for inpatient units. And G building at Kings County Hospital, it was world famous. No matter where in the world we go, where, people do G building. And because very famous criminal cases also, those patients were admitted there. And also, it had horror image as well as very effective treatment. I once, in the emergency room, somebody walked in and he said that his voices told him, he's from England, his voices told him, go to G building and get admitted. So he came from England to here and came directly to King's County. Initially, I thought it was delusion, but then I looked at his passport and all. And so that's how famous it was, for how good it was. And in those days, if you spent one night working in the emergency room, you would have seen it all. Colleagues in other hospitals, but they wouldn't have seen catatonia for 6 months. But if you spent one night in King's County, you would do that. So it was really a pleasure to work with. This is a picture of Dr. Pardes. And we also had therapeutic communities. There were units, there were acute care units, but there were also units with a long-term stay in G53 and then nursing station 52, where the focus was, again, not simply medication and individual psychotherapy, but also really community-oriented, which was good. I hope we can revive that kind of treatment. And which also gave us an opportunity to get to know our patients in depth. We used to do psychotherapy with inpatients, which was, again, helpful. And we also had psychodrama, both in nursing station 52 and G53. So we had quite a variety of exposure to people's internal life and how they express themselves. We also had family therapy in and outpatient. So a lot of good training. The thing which was lacking was behavior therapy. And it was just before the year of cognitive behavior therapy. So I went out of my way to learn behavior therapy and hypnosis, but the program did support it. And all the residents were in psychoanalysis or in psychoanalytic psychotherapy themselves, without any exception, because it was felt it was important to learn about ourselves. And also you see a model of how psychoanalytic psychotherapy was conducted. And we also did a group therapy, and the program allowed us to go out of our way to get supervisors. Me and two of my co-residents, we would go to Staten Island and got supervised by Dr. Milton Berger, who was really a famous group therapist. And also, the other thing is there were a lot of psychoanalysts in the community, and residents would go during the day to their office and get supervised and then come back. Some analysts came to the premises themselves. We also had a psychosomatic medicine service. This is Franz Reichsmann. He was an internist, but he got trained by George Engel in Rochester, who established the first psychosomatic medicine service in the USA. So we would spend a lot of, we also had internists here, like one person, he's an internist from Switzerland, Dr. Radvila. He did a fellowship with me. And this Dr. Rajapaksa also was an internist. So it was a really, again, we will look at patients, looking at detailed approach, largely psychological things, not, looking even into the unconscious. We used to speculate about attachment and disruption of attachment, repressed emotions. Yeah, and you have Dr. Levy. Yeah, one more thing I need to tell you is Eli Friedman was responsible for establishing nephrology service here and one of the earliest hemodialysis service. And so that gave an opportunity for Dr. Reichsman and Levy to do one of the early studies on patients on hemodialysis. And, okay. And so again, there were a lot of research opportunities also. Okay. Dr. Michael Blumenfeld, he was on the liaison service, and he was one of my earliest supervisors. Dr. Glickman was the director of psychiatric consultation service, and he was very action-oriented. We also had a Doctor of Medicine research training program under the leadership of Dr. Norbert Friedman. I got my Doctor of Medical Science degree. Steve Friedman was the presiding officer of the committee, like my advisory committee. And we had world-famous psychology researchers, Witkin on field dependence test, Leonard Rosenblum, primate research work, and of course, Henri Begleiter, even in the 70s and early 80s, he was world famous for the work he was doing on alcoholism. And again, you'll hear more from Jackie Myers about Dr. Begleiter. And so Dr. Fagelson became a chair in 1978. Unfortunately, the psychoanalytic, I don't know the background to this, Psychoanalytic Institute decided to move out to NYU, which was a significant loss to Downstate. But this, in the early 80s, Dr. Begleiter's lab really made a groundbreaking discovery. It was published in Science in 1983, which really established heritability of susceptibility to alcoholism. Again, you'll hear later about it. And in 1983, Dr. Fagelson invited Dr. Steve Friedman and me to form a phobia and anxiety disorders clinic. And this was very helpful to the community and to the trainees, and both of us enjoyed. We are both clinically oriented as well as research oriented. Some of the publications, they have a number of citations. And we are also fortunate that Dr. Bernice Porgier, she was an early associate of Dr. Begleiter, and that has really helped. After his demise in 2005, Bernice has really sustained and even taken it to newer heights in doing, it's their research program to this day is one of the strongest research programs. Basically, at several points, our department had half of the entire research funding for the entire medical center, right? We're such a small department. It's largely due to their grants. And other people like Dr. Schooler and other people are also having grants. And Dr. Friedman, okay, and he had been mentoring many people on a CBT, which was, we still, again, are quite strong in dynamic psychotherapy, but also CBT is quite strong. Dr. Scherl he's a psychiatrist. That's the reason I have his picture here. He became president of the medical center 1981 to 1993. He was responsible for building the health science education building. And this is when I got installed as the president of the Brooklyn Psychiatric Society. I invited the APA president, Dr. Jack McIntyre. You can see Dr. Fagelson here. And as you know, Dr. Clare mentioned, it's very important for you to reach out and be involved. And when you get to know the leaders, it's mutually beneficial. It helps you a lot in leaders at various levels. It helps you a lot in your career development and personal growth. And Carl Cohen, he joined the department in early 80s. At that time, geriatric psychiatry was really a fledgling subspecialty. He did immense work in developing it to a center of excellence that we have now. He was very good in teaching as well as grants getting and clinical research. He has done research on what happens to patients with schizophrenia as they become older. This is all community psychiatry research. He is also very aware of social determinants of health. So he was a unique person and his loss is a big loss to us. And we also had Leonard Rosenblum. We had a very good non-human primate lab, which Dr. Rosenblum did really pioneering work on separation and the stress, and Dr. Friedman and others developed a model on a non-human primate model for studying anxiety disorders, because animals don't complain about anxiety, right? So you have to develop a model, behavioral model. And Dr. Copeland actually developed his research career here. He did seminal work on neurobiologic changes induced by stress of disruptions in mother-child bonding. Dr. Martin Kessel, at one point, Dr. Fagelson was doing everything. Chair, dean, and interim president. So I don't know how he managed to do it. So I'm not exactly sure whether Dr. Kesselman was interim chair while Dr. Fagelson continued to be chair. I don't know, at some point, Dr. Kesselman became chair, and Dr. Goldfinger was his vice chair. And Peter Wyden, he's a very famous clinical trials investigator. And so he was there for a brief period of time, and he was chair of the department for a couple of months. And then Dr. Goldfinger joined us, and he was chair from 2003 to 2016. Dr. Goldfinger did a lot for getting the residents involved in community psychiatry. Many of our department is well known for community psychiatry training, and he really set the stage for that. And we also, in terms of psychiatrists, we had Drs. Patu, and they, brought in genomics research. And so even though they have left, we are really fortunate. Some people stayed behind, the dean and the vice president, the senior vice president for research, both have been very supportive of not only keeping genomics researchers here, but also recruiting, because to this day, this continues to be an excellent research center, and they get a lot of research support. And also they happen to help train a lot of our students and residents. And Dr. Fanous was a chair from 2016 to 2021. Dr. Patu brought him again because of the genomics research. Okay, now I'm the interim chair, and so it has been really a pleasure. The dean has been very supportive, and it has been a pleasure working with excellent chairs, from other departments, and with all of you. In terms of education, Dr. Kavi was a psychoanalyst who was very influential. Dr. Garrett, he contributed to CBT for psychosis, and he was very good in educating our residents, and he's internationally well known. And Dr. Myers, again, we are fortunate to have him. He has contributed a lot and continues to teach in psychotherapy as well as suicide prevention and advocacy. And Dr. McAfee, again, we are very fortunate to have him. You all know, how much he does. And Dr. Catherine Gallanter in child and adolescent psychiatry. Dr. Reinhardt in geriatric psychiatry training. Dr. Ananthamoorthy, she really runs the show at Kings County Hospital, which, as you know, it's a major educational center for us to this day. You will hear more about the excellent services she runs. Dr. Fiola, and again, people before him did a lot of work for undergraduate education, as Dr. Daniel Friedman. And Dr. Berkowitz, she was really a backbone of our residency training for a number of years. Now she's working mainly with the students. Again, does an incredible amount of support as well as advice for the students. And we continue to have, as I mentioned, Jackie Myers, Tim Begleiter, Roseanne Peterson, Sivan Kendrick, Peter Barr. We have a really strong team in terms of genomics and social determinants of health and artificial intelligence research. And we also have excellent clinicians at both Kings County and UHT. Okay. This is a picture of our trainees a couple of years ago. And also our residency program does well, not only in national presentation, but in competitions called mind games, which are Jeopardy-style things run by the American Psychiatric Association. They had been finalists, top 3 teams out of more than 450 residency programs in the country. Okay, so again, thank you all, for supporting our department, and I look forward to working with you.
Thank you, Dr. Viss. So that gives you a sweep, and here we go. Dr. McAfee, who you just saw his picture, he's our Director of Training as well as Vice Chair of Education. He's going to talk about achievements of our current and graduating residents. Thanks.
Good morning, everyone. It's so nice to see everybody here from multiple departments at every stage that the university supports. It's a privilege to present to all of you today, and I want to thank Dr. Myers for including me on the planning committee. I can tell you, if Dr. Myers asks you to be on a planning committee that he's running, join, because he does all the work. He has done an incredible amount today, and I also want to thank Lauren and Barbara for everything they've done. I have over-prepared, which won't surprise anybody here, so I will flip very quickly through slides that Dr. Viss covered and other people have covered, because we didn't pregame this because we had the APA kind of keeping us all busy over the last week, but it is a privilege. So I think of residency training programs as carrying on tradition. Like, I'm just the steward for the time that I'm here, but I have to learn about the traditions that came before me and then try to build some while I'm here, and I'm not going to be here forever, as none of us are. So this is the language of the ACGME that I think really speaks to what we do, and yet each program has to do it their own way and make it special for them. I'm glad that all the fellowships were mentioned. It's my understanding that Downstate's residency program in psychiatry is in its 57th year, and we'll be celebrating the 57th graduation commencement in just about a month from tomorrow, actually. So when I recruit resident applicants, I show them this slide, which I won't read to all of you, but it is really my belief and observation that training in psychiatry in this program exposes the trainees to psychiatric care in every single setting that's offered in the state of New York. Every single setting, with the exception of maybe a boutique cash private practice in psychiatry, but I've invited residents to come to my practice, and some have taken me up on that to see patients with me to kind of see that part of the world. I'm very proud that we have a lot of child psychiatry early on in training, and Dr. Ananthamoorthy and I are constantly working to bring child training to outpatient residents as well. One thing that you can say you walk away with after doing this program is independence, and how to walk into a new medical environment knowing how to get on that stupid EMR that's different from the other 6 that you already know, and how to make sure you're on time for patients, all that stuff. Our residents train and become just unbelievably facile in doing that. Psychiatry residents, for the history of this program, have been involved in GMEC endeavors. Right now we have members on the DEI committee there and on the wellness committee. And just when I got here, Dr. Viss and Dr. Fanous had worked to develop the ability to have process groups. So our residents in the 2nd, 3rd, and 4th years every week meet with one another and an outside facilitator to process what it's like to be a resident and a resident here. It's been roundly stated that we train just about as many programs as any other program in the country. These are our affiliates, which include 2 city hospitals, a VA, a state psychiatric hospital, a university hospital, and a private voluntary hospital up at Lenox Hill. So the residents really do see things in all kinds of settings, and Kings County, of course, is very special for all the reasons Dr. Viss mentioned. Within our program, we are ever looking to have electives that expand the exposure that residents get outside of the core offerings of the program. And so I've listed some of the electives that we've developed since I've been here. And these are in addition to the Copland Clinic, which already existed. And we now actually provide senior residents in the HEAT Clinic all year round. That's been going on for 5 years now, which we're very proud of. And our residents have found some of these electives themselves. The Motherhood Center, which is a premier perinatal health treatment center on 33rd and Lex, forensic psychiatry at Rikers, and ECT at Bellevue. These are all resident-driven elective opportunities that we've backed up. So you're welcome to do the same thing. In our program, we have a chief resident for every one of the 4 training years, and for a couple of years now, we've had 5 residents because this is a very large, very busy program, and this helps to manage the program as a leadership group in the residency training office. Here's one of my favorite pictures of the chiefs from last year and the chiefs before that. Speaking of tradition, when I joined, I was welcomed by Juliet Arthur, who, if you can be internationally famous in resident program administration, you are Juliet Arthur. She has won all of these local and national awards that you see on the screen, and right up until she shifted jobs to join the Central GME department, she was given the ACGME's nationwide award for resident coordination. I mean, she is truly spectacular. And I still look to Juliet as a friend and an advisor. She's presented nationally in this Residency Program Coordinators Forum that she founded and continues to co-chair. She was amazing, and I think speaks to the great tradition in this program. This is a word cloud of the last 5 years of medical students who have matched with us. And I'm thrilled to say that Downstate is the largest word on there, followed closely by St. George's University, which has a very, very close working affiliation with the Health and Hospitals Corporation. So it's no surprise that St. George's students get to know us pretty well and match with us as well. What you'll also see on the screen is a number of international medical schools. I have fought what I've been told by my chairs my entire career, that we only want American medical grads and osteopaths. I have not listened and haven't gotten fired yet. I think that having international medical graduates in any residency program is critical, especially when those people match the community that the residency treats. And so we have continued that great tradition, and I hope to continue it moving forward. Now, I put this slide in here so that I would pause, and I mean this deeply and sincerely. I can only mention a couple of people in the time that I have. So if I leave someone out that you think needs to be up here, please forgive me. Tell me about it later. I'll add it to the presentation. As Dr. Viss mentioned, we have so many laureates of this department that you can't capture them all. So I will mention people for the various reasons that I am, one of whom is Michael Reinhardt, who's going to present to you later anyway, so I'm just mentioning him out loud here. So many of you in the room might not know Dr. Sharif, but I got to know him through his online presence. But he was the first resident to join the dual residency PhD program here when it was still affiliated with NYU. And he was one of the early adopters of computer-based models to study schizophrenia. He's been awarded a number of things that you can see on the screen, and I've been told from people who do know him and who trained him that he's very proud of the training that he got here at Downstate. The same holds for Ipsit Bahia, who I was lucky enough to meet, I think, 2 years ago. He now serves as the interim chief of the Division of Geriatric Psychiatry at McLean and is the director of the Digital Psychiatry Transformation Lab up there. And yes, this is Saeed Hashem's boss. You would think Saeed Hashem doesn't have a boss, but he sort of does with a downstate grad, which is crazy. And he serves on all of these, obviously, nationwide recognized council. He's a specialized editor of the American Journal of Geriatric Psychiatry, and again, is an award-winning psychiatrist. Known to just about everybody in this room, someone that is a colleague who I also am lucky to call a friend, Dr. Georgia Gavaris, who is boarded in psychiatry, child psych, and then addiction medicine, which she did separately, and then later trained at the William Allenson White in their eating disorders program. Georgia's got lots of hidden secrets. You have to really get to know her to learn most of them. I met her when she was a training director in the Child and Adolescent Fellowship at St. Luke's Roosevelt, which it was then called. We actually met around a pool at an ADPERT meeting, and I liked her verve and spunk and ability to speak truth to power sometimes. When I then, years later, came here and met the faculty at Kings County, Georgia was the program director of the CPEP, which there we were again. And She's now the co-founder and chief medical officer of Psychiatry, which I will put the brand up there. I've told her and her co-founder, Rob, that they have begun a movement into what I think should have happened 60 years ago, is people being able to use their work-supported health insurance to get mental health care. People with real jobs that can only go after work and want to use their health insurance. And you've now seen a rash of these companies all over the country, especially during COVID, reaching patients with mental health needs through televisits. And I'm not even going to guess how many states Psychiatry is in. The funniest thing about that is that every time Georgia expands that practice into another state, I have to sign her residency verification. So I track the states through that. But we're very proud of her. And then I'll mention Dr. D'Souza, who is a distinguished Downstate alumnus, who is, as you can see here, professor of psychiatry at Yale, who has done fellowships in psychopharm and neurosciences. He directs all the programs that are on the screen, including the Synergy program, where he is one of the nation's leaders in studying the neuroactive properties of psychoactive compounds, most especially the cannabinoid system. He's been pleasant enough to give us grand rounds, and he still teaches. I'm getting the high sign that I have to catch us up. So you're going to do a lot of reading while I do fast talking. More close to right now, some notable alumni are our public psychiatry folks. And Alan's going to be president of New York County District Branch, while Sam is president of the Brooklyn Psychiatric Society. This is crazy. This is amazing. And I'm very proud to say, and Sam was blown away, that the medical students here at Downstate voted him into AOA as a resident member. That is really cool. And as Dr. Clare, I wish she was still here. Somebody sent her this. But we also have 3 graduates of our program that have gone into women's mental health. And when Bronwyn matched into NYU's peri-mental health program, there were only 8 programs in the country doing this. And I would say NYU, Columbia, and Harvard are not bad programs to be in. My predecessors running this training program are as lauded as Dr. Viss mentioned, so I won't belabor the point. But I do want to thank Ellen. Dr. Berkowitz, thank you for your friendship over these 25 years that we've known each other, and for helping me to prepare this presentation today, and for all that you've done for the training program. Your signature is everywhere, as they say. Our residents have a very high subscription to fellowship matches, and I've done a pie graph of the last 9 years. You can see Child really runs the show for us, and I'm thrilled that we have Dr. Gallanter's program here. But we're also moving into places like informatics. Connor Paulette is going to start his 2nd year as the only psychiatrist ever to be matched into NYU's informatics fellowship. So he's really bringing our name and our discipline out there. I will just tell you that this strikes fear in the heart of any training director. These are the results of the ACGME Anonymous Survey. And we have hit an equilibrium now where we've got some things to follow and manage every year. My first 3 years are on that top stanza there where we started that up arrow, and now we're just hitting a stride. We've always got to chase stuff, but we are at or above the national average on more than 60% of these metrics. Our board rate is far above the national average, and we've never had a person who's not made it through the boards once fail it more than once. So we do very, very well. And I'm going to blindingly quickly go through these. Our residents publish in some of the greatest journals in the country. Mitchell Bain and Isabella are both Downstate students who won the #1 paper in child psychiatry last year that's unpublished by the Training Directors Group, and they joined us at ADPERT a couple months ago. One of our chief residents won a SAMHSA fellowship as an intern, which I've actually never heard of in my career, and you all know about Pranav's peer training program. He's also won a Laughlin Fellowship, which is probably one of the top 3 or 5 most prestigious fellowship that a resident can win in this country by the American College of Psychiatrists. And there's Gene Berenson conferring his certificate. Hagar Kandel won one of the 5 in the country IMG fellowships last year. She's also the inaugural resident graduate of the LEND program here. Sam Jackson's the only resident I've ever had win a GAP fellowship, and there he is with Gabby Gifford. Sam is going to be interviewed by the New York Times this week, and he had an audience with the governor of Hawaii because the governor of Hawaii is trying to solve a homeless problem and reached out to our graduate to figure out how to do that. I'm very, very proud of Sam. Dr. Viss mentioned our Mind Games team. I'm so proud of them. We have kicked butt, and we're going to come back strong next year. Our work with our affiliates are rich and strong, and one of the ways that's evidenced is by the fact that our faculty and residents are honored every year at Doctor's Day. And our residents have fun at retreats and mini retreats. And this is a National Neuroscience Curricular Initiative project to create neural circuits by coloring baked brain cookies that almost had me decompensate because I am not a baker, but I did my best. We had a really fun time in this room right before the holidays. We have outings with our faculty. I'm going to cry. So our residents get married. In that left picture, the specialty of two residents in the same class getting married is only bested by the fact that another member of their class married them. Sean Yancey is right there. Noor, who's training in forensic psychiatry at NYU, will be back in July to work at Kings County in the CPEP. I'm so delighted. That's the wolf pack there with her at her wedding. And Sam and Roxy were married about 3 weeks ago in a private ceremony by a judge, a Miami-Dade County judge who you might have seen speak at the APA, who's become a very special mentor to Sam, who flew to Chicago to officiate at their wedding, which I'm thrilled about. And looking ahead, you can't do this work without a partner. And Junaid, thank you for being everything you are. One of our graduates, who is the site director of the work that we all do at Kings County. Audra has joined us after many years in undergraduate medical education. And yes, Audra's fantastic. And we are working on moving forward. And I'll just let you scan that slide. We are excited to work in simulation training with Kings County and Downstate. We're ever adding to our QI stuff. Sorry. And you can't be in the now if you're not in the now. So we have a social media group who insists on getting our name and word out there, and they made me promise that I show this. So where I go when we're dancing. This is how our interns do sign out. I love that. All right, and then Vis, Dr. Vis, congratulations to you. Dr. Vis competed in the Masters Mind Games. The first year it's there, and he's one of the 3 finalists in this online test, and then competed live at the APA this past Monday. And that's just a snapshot of Vis giving the opening address at the opening ceremony of APA. Thank you all.
Thank you, Dr. McAfee. Good news and bad news. So the good news is that this is a great department. There's a lot to talk about. The bad news is that we're roughly 20 minutes behind. It's my pleasure to introduce Dr. Renuka. I'm Ananthamoorthy, who's the Chief of Behavioral Health across the street at Kings County, providing outstanding behavioral health services in a challenging environment. Thank you, Dr.
Good morning, everyone. It was really happy to see what Kings County has contributed to SUNY Downstate for all these years, and I didn't know about that part of the history, and also the G building. So for me, it's more the R building, which is a newer building, which I know about. But I'm really happy to see those slides. And I really want to like to take this opportunity to extend my sincere congratulations to Dr. Viswanathan for his exceptional contribution to the field of psychiatry over the years. His dedication to advancing mental health within the medical realm and advocating for policy changes to diminish stigma and enhance accessibility to care are truly commendable. Moving forward, I'm going to focus on my presentation, which will revolve around providing outstanding behavioral health services in a challenging environment. Hopefully I know how to do this. Next. Okay. So we are evidence-based, patient-centered, and trauma-informed team that strives to integrate mental health care, substance use treatment, and physical health care to improve the well-being of the individuals utilizing our services and the community. We provide a whole patient approach to the care. So we have a comprehensive psychiatric emergency program, and it includes our extended observation unit and mobile crisis team. And the CPEP provides care for over 500 members of the community each month. And the mobile crisis team usually sees closer to 125 visits each month to care for the patients in the community. And you can see the visits, it's really, you can see the crisis team in the community seeing this amount of patients. We get closer to 500 referrals, but half of them is where we become successful. For us to say successful is to see someone in person. You can't just see a parent or a brother or sister and say it's become successful. You have to see the patient. So we get 500 visits, closer to 500, and we are successful with half of the patients. And the acute child, and we also have an adult and child inpatient program, and we have service includes 4 adult inpatient units, and an extended care unit, and a unit for individuals with intellectual disabilities and mental health issues. And we have to say this, we partner with the Office of Mental Health and Office of Behavioral Health at Central Office to open these 2 units. And when you look at this, there are a lot of patients with ID, intellectual disability, goes to an emergency room, and then start with many medication because they're so agitated, and they end up back in a very bad shape to their residence or to their home. So this unit really was the first one to be developed with a collaboration with Office of Mental Health and OPWDD system. And we were able to start a couple of years ago, and we have a census of 12 beds. And we are able to see a lot of patients, and we really look at the diagnosis and the treatment of this patient and medication management. And we are very successful in taking care of these patients and not to be lost in the system. And the extended care unit also is a partnership with the Office of Mental Health as well as the Office of Behavioral Health. And we opened up a 25-bed unit. And to really think about these patients who keep on revolving around in the hospital system, to really reduce that, and also with the street homelessness where our patients are coming in with no housing and living in the streets and not able to take care of themselves. How do you really provide care and support them? Just having a 15-day stay or a 5-day stay is not enough for these patients. You really need to keep them for a long period of time to do a rehabilitative work with these patients and then provide that support what is needed. So we just opened it a year ago, and you'll see some data with that too. And then we have the 3 child adolescent units, and 1 unit has been really care for adolescents, 2 units for care for adolescent, and then 1 unit, we have a first episode psychosis unit. And that's patients we care from age of 16 to 23. And that's a very specialized unit. We partnered with, again, with Office of Mental Health and Office of Behavioral Health to really open this. Remember, these kids, when they come in at the age of 16 or 17 or 18, when they have their first break, and the family are planning to think about, oh my God, my son is going to go to college, he's going to go to work, and then you have the first break in that, that's a really a scary moment for a lot of families. And this unit specializes not only just medication, but in care of not only to make sure that we meet with the family, educate the family, as well as provide the support in an integrated way. So the acute care units are keenly focused on the care of the members of the community at risk for suicide. One thing, and I was talking to my friend this morning, how this has been changed in the last few years in Brooklyn itself. When I came from Queens Hospital, what I see over there is most patients were high risk for suicide. When I came to Kings County, it was more high risk for violence is what I saw. But there is a sudden shift in the last few years. I'm seeing more suicidal patients who are high risk for suicide are coming in. And that's an interesting shift in the way what the patients are coming in. It's not anymore that high-risk behavior, I'm going to beat up somebody or I'm going to hurt somebody, but how am I going to hurt myself? And what kind of care I need in an inpatient setting, and how do I take care of these patients while they're in the inpatient setting, and also to try to connect them to the care is very important. For us, we need to recognize those patients who are coming in with those high risk, and then how do you treat them while they're in their stay, and how do you connect them to the care? Because it's really, we are discharging them back to the community, and the community needs to protect and provide that support for these patients. So our specialized units, which is called the ID unit, the ECU, and the first break, are filling a need in the community. So you can see the ID unit, which was started on April 23rd to all the way now. We started with a low census because of staffing issue. Now we are going up on a census. Currently, we have 14 patients. We are moving up to 25 very soon in a month or two. And you can see the census and the discharges happening in those units. And the ID unit, same thing. A low census of 10 maybe the maximum we take, because we can't handle up to 12. It becomes very risky to have a patient with intellectually disabled. So, and how many discharges we have done, because their length of stay in those two units are much higher than a regular unit. And the discharges from the first break unit, you can see for the year, we have discharged closer to 14 patients last month. And the housing placement from the extended care unit. I told you guys that we started with a very small census. And when you look at it, these patients, how did the placement of patients when we admit, so we had discharged out of the 15 patients who came in, and we were able to discharge them to the OMH supporting housing. 9 patients who are really street homeless were able to place in a housing. It's really a tremendous work which is done by the group of people, because it takes a lot to find a housing in New York City. To get them placed with the OMH help, it's really great. And then we were able to get them back to the housing, to the home they came from, with working with the families. We sent 5 of them to the medical respite, and 2 of them ended up in a state facility because they couldn't handle after being there for three months. Still, they were struggling with their psychosis, so we had to get them into a state facility. And then 1 of them ended up back in the shelter. So the follow-up care is very important for our patients. Remember, we cannot just discharge them to wherever they go. We need to make sure that they also connect to the care. So when you look at it, when you compare with all the other health and hospital, Kings County has the highest rate in the connection to care compared to, so we are 63%. We connect within the 7-day follow-up rate for the last 2 years. The 30-day follow-up rate is very higher. It's 79% because we have a we have a monitoring referral linkage team where we make sure that the patients, if they don't follow up within 7 days, we keep on calling them, making sure that we reach out to them, to the family, and to bring them back and connect them to the care. And that's why your rate with the 30-day has gone up. And this shows that we are able to connect patients and also retain patients in the system. The adult outpatient program, again, this is again comprised of mental health outpatient clinic. We also have a co-located primary care clinic, which is very important for our patients because we don't want them to go into the regular primary care clinic where they are lost in the care. We want to make sure that our internist and the nurse practitioner who work there take care of these patients, understand their mental health needs as well as the behavior and the primary care needs, and work with them closely. So they are not someone who will see the patient for 5 minutes or 10 minutes, but they take up to 30 minutes to see a patient and evaluate, and a psychiatrist become a consultant to that clinic. And then we have a huge walk-in clinic where patients come in through our referrals. We have a partial hospitalization program for adult. And I have to talk a little bit about the esketamine clinic. Later I can show some data, which was really taken by the lead by the residents. And the residents took it on, and they're really developing that program, and I'm so happy to see that. And also, we are also submitting a funding for a TMS soon. And I'm hoping that will be also taken by the resident and run that clinic. And the only thing we are looking for a space, so hopefully we'll get those 2 clinics next to each other, and we'll be able to run that well by the residents. And we also have a long-acting injectable clinic, and you also will be surprised to see how many patients are on a long-acting. We have a family justice center and a domestic violence clinic and a Kings on Track for our newly diagnosed first psychotic break patients. We have a substance abuse services, which includes opioid treatment program, which is a methadone and a buprenorphine, and a substance use treatment for adult day treatment program, and the ED leads team, which really does, the addiction team goes all the way to the medical emergency room, medical inpatient, surgical flows to provide the support for the patients, because that's the area we really want to see those patients who are withdrawing from alcohol or drugs, to treat them and to connect them to the care. And we also almost close to finalizing on the office-based opioid treatment in the behavioral health primary care clinic. We're just working on the final part of the billing and everything. Hopefully that will become successful in the primary care clinic. Increasing access for the community. Again, we see a lot of patients in the outpatient clinic. Census is really, the visits has gone up, and it's 3,600. If you all look at it, there's an increase in mental health crisis. A flow to our clinics is very important for us. We don't want patients to be waiting outside and waiting for an appointment. We have an express care, which was developed by the Central Office of Behavioral Health. So if a patient cannot get an appointment into a clinic right away, we have a bridging in the express care, virtual express care, where the patients can be seen in the virtual express care and then come to our clinic. So far, we are the highest to use the express care, and we have connected close to 700 patients in that express care before they get connected to our outpatient clinic. So that's a bridging. It really helps us to keep our patients safe in the community. And the adult primary care clinic, they see closer to 1,500 visits. And you can see the data when you compare these patients who are coming into our clinic. You really want to make sure that their diabetes, the metabolic is also under control. So you can see in the slide the Kings County for the For the whole hospital, they are at 66.2% control of the A1C, but you can learn the BHPCC, which is a behavioral health primary care, we are at 72%. So we are doing better than the regular primary care clinic in taking care of the diabetes in these patients. The number of LAI administration in the primary care, we administer closer to 645 long-acting injectable. And this is very important for our patients. Remember, our patients go home, they don't take medication, they don't follow up. We really want to keep them connected to the care, and this is the biggest clinic almost in the H&H system. And we follow them. If they don't come for the LAI, we send mobile crisis. We also make sure that mobile crisis gives a long-acting injectable. During the COVID time, that's a very important thing we did with the mobile crisis team. We had a nurse over there as well as a resident who rotated through the mobile crisis and was able to go and give the long-acting injectable to the patient, because we don't want them to miss an injection and ending up in a psychiatric emergency room in a very bad shape. So esketamine clinic, you can see there are patients, they have enrolled closer to 7 patients, but there are some more patients getting enrolled soon. Pre-treatment, you can see the score was 29, but the week 8, it was 11, and it's really run by the residents with the supervision of the attending. They're really doing great in that clinic. Increasing access in our substance abuse program, and you see there is a lot of opioid crisis going on, and there is an increase in census. So in February 23, the census was 167. Now we are closer to 251. Same thing with the opioid treatment. Patients treated with bup, you can see the name of the new patients, how many we see, the volume is compared. So when you compare, there is 126 patients were treated with buprenorphine for opioid disorder in March 2024, compared to 85 of last year. Same thing with sublocade. 66 patients received sublocade injection in March 2024, and 171 patients have received the first injection, and 66 remain, and 60% got a second injection, and 51% made it to the 3 months mark, and 34% made it to the 6 months, and 39% made to the 9 months. And the ED observation, rapid microinduction, which we have been doing it in the emergency room, and you can see the success rate also, which is 24 out of the 33, 73% where we are doing microinduction. Hepatitis C treatment is really a very important role we are playing in the opioid treatment program, and we have an internist who also a primary care physician who covers the opioid treatment program, and we always look at hepatitis C, and that's very important thing now with the DOH mandate that everybody should be checked for hepatitis C. But this program was started many, many years ago, and we have a total of 43 patients were treated for hepatitis C. We identify, and we also currently in treatment, and there is also we treat them while they are in the opioid treatment. Child and adolescent outpatient program, we have a mental health outpatient clinic, we have a pediatric collaborative care, children crisis CCIS program, a DEC, and a school-based satellite services. Currently, there is 1 satellite clinic at Ryder Elementary, an additional of 11 new satellite clinics in local school. Out of them, 3 we have already enrolled, and for a few more we are enrolling the next few months. CL services, again, it's a busy service. We see a lot of patients, and coverage is done by residents as well as the attendings 7 days a week. And we have the new thing what we started to do is licensed creative art therapists. We introduced licensed LCAT into this program because there are many patients who stay there longer, and some of them are with mental illness. So we try to work with those patients by providing that therapy for those patients who are staying in the ALOC unit, and also using LCAT to go around and with challenging patients who are becoming challenging in the medical area, to provide that support for the medical team so that we can provide that appropriate care and reduce the length of stay in the medical unit. And we are also expanding the licensed creative art therapy to who have started groups already in the sickle cell clinic, and we are also looking at more other ways of integrating them into other clinics. And we have a neuropsychologist who come in every Friday to really work with the resident students as well as the attendings to help us to really differentiate between the cognitive part and the schizophrenic part. Sometimes it is very easy to say you have schizophrenia, but really to understand there is maybe some neurological element to it, and then not to have a label of schizophrenia. So she was doing a great work, and she's been with us for many, many years, and it really helps us as for the clinicians to understand the differential diagnosis of patients and what kind of treatment need to be provided for them. So the next steps. So what we are trying to do, we are trying to apply for the Certified Community Behavioral Health Clinic, and I know that's something which we've been, most of the community clinics will be applying for it, but I think we have, out of the 9 elements, we have almost 7 elements in our clinic, so we should be able to apply, and hopefully we'll get that as part of the OMH submission. And also we are going to have the increasing access to the esketamine clinic, and opening the space for the iOS team to serve patients more for mental health, medical, and substance abuse. We have the iOS license, but we don't have the appropriate space, which we are currently working on, so that we can move some of the patients who meet that criteria and to treat them in a more on an integrated way in that space. And then to increase access to all mental health clinics and SUD clinic, and continuous support to medical, surgical flows, and also specialized clinics. And in closing, I wish to express my gratitude to SUNY leadership, Dr. Viswanathan, Dr. Myers, Dr. McAfee, Dr. Begleiter, and other esteemed faculty members, residents, and students for the ongoing support in fostering innovation in mental health at Kings County. Thank you.
Thank you, Renuka. Great report. I'd like to welcome Dr. Jacqueline Myers to the podium, and she is an associate professor in the Department of Psychiatry and Behavioral Sciences, and she's going to talk about innovative scientific contributions of the Henri Begleiter Neurodynamics Lab and the Genomics.
All right. Well, thank you again for inviting me to be here today. And I'm going to be talking about some specific areas of research in the department, but clearly, as we've heard this morning, I'm presenting work that's really standing on the shoulders of giants in our department for decades prior to when I came here. And though I'm relatively new, having been here almost 9 years, I just want to acknowledge all of the amazing researchers that we have in our department that I won't be talking about today, notably Dr. Nina Schooler, Dr. Gallanter, Dr. Copeland. Oh, thank you. All right, I'll use my theater training to speak into the mic. And all the other amazing researchers that we've had. And today, I'm going to be talking specifically about work going on in the Henri Begleiter Neurodynamics group, as well as some of our work in genomics. So perhaps one of the biggest researchers in the department that I need to start by acknowledging is Dr. Henri Begleiter himself, who, along with Dr. Bernice Porches, started this work that I'm going to be presenting here in the 80s in our department. And I was hearing that our department was 57 years old. Is that what someone had mentioned? Oh, the residency. Okay. All right. Well, this project that I'm going to be focusing on telling you all about today is 40 years old. So it's been a mainstay in the department for a very long time. And so the group, started by Dr. Henri Begleiter and Bernice, has now grown into this amazing group of researchers that I have pictured here. We kind of have our main focus on studying addiction, primarily alcohol use disorders, but also all of the comorbid substance use and related mental health conditions that we know co-occur with alcohol use conditions. I'm happy to represent this group of researchers. I'm seeing in the audience a few of whom are here today that are doing work in terms of brain functioning, genomics, looking at social determinants of health, and looking at neurodevelopment across the lifespan. So this project that I mentioned was started here in the 80s in our department. Is called the Collaborative Study on the Genetics of Alcoholism, though it's being rebranded with alcohol use disorder this year. And it says 30-plus year. This needs to be updated. It's 40-plus years. We're headed into our renewal as we speak. And the main focus of this is to study the role of genes and the environment and brain and behavior related to alcohol and associated comorbidities across the lifespan. All right, a lofty goal. But this project started as a family sample that Dr. Begleiter and Porches were ascertaining here in Brooklyn, expanded to 11 sites throughout the United States, and has now reached over 17,000 individuals across 2,000 families, or plus families, that now comprise this amazing sample. And originally, the group identified individuals who had an alcohol use disorder and all of their family members that we could find. This is that original sample that has now grown into 17,000 people. This is a diverse sample, and it's genetically informative as well. One of the amazing things that the founders of this study were thinking about decades ago was really collating all of these different types of data on the same individuals, which at the time was sort of studied individually. And now in this age of AI and big data, this massive amount of data that we have, thousands of traits and characteristics, both biological, social, environmental, on the same individuals is some of the most valuable data in our fields. In 2004, we began studying the offspring of the original families. So instead of just having this adult sample and their family members, now we also have what we call the prospective study, which is a longitudinal developmental study of young people that came into the lab as early as age 12 and were studied every 2 years, again with this rich battery of biological and social information. In 2019, we did a Where Are They Now study with both those original family members as well as the young people that were their offspring. And we're currently, I skipped ahead, heading into a renewal phase where we're hoping to continue individuals, to follow individuals into their middle and later life and really do a better job fleshing out the second half of the lifespan, as most of this work has focused on the first half of the lifespan. I have this impressive number here. We have over 43,000 total interviews on individuals from age 7 through 90, and this really rich array of data that we could use to study mental health across the lifespan. Delving a little bit more into the characteristics of the sample here, but really just focusing on our next steps where we want to be able to use this data to delineate the longitudinal course of AUD and other mental health conditions, including recovery across the lifespan. And we are now, I think Dr. Viz had mentioned, part of a mental health and AI global center at Downstate that we partnered with Upstate to really integrate all of this data and use the most cutting edge methods to kind of move to the next stage of understanding of mental health. So just a moment to brag about my colleagues here. This U10 mechanism through the NIAAA, which has been funded since 1989 by the NIAAA, is continuing with the renewal, as I just mentioned. We also have a bunch of spin-off projects from our COGA study, which has allowed a lot of our other faculty members to shine, including Dr. Keenreich, who we have here in the audience here today, who has an independent grant focused on machine learning and integrating all of this fabulous data. We also have an offshoot study focusing on COVID-19 stressors and the experience of individuals with their substance use disorders throughout COVID-19. And I lead another project focused on traumatic stress in early childhood and the relationship with PTSD and substance use disorders throughout the lifespan. I also want to highlight that we have collaborations with individuals across campus, including those in the School of Public Health. We are looking at mental health and substance use disorders, along with loneliness and different aspects of social connections with Dr. Wilson in public health. As I'll mention a bit more, we lead a number of international consortia in the area of psychiatry. Our group has an impressive amount of articles every year. And I'll just, highlighting a few of our faculty members here in excellent journals and just, continuing to publish at a rapid rate every year. And it's just really amazing to see. So I also want to take a moment here to acknowledge some of the work going on in genomics by our colleagues in the Department of Psychiatry. You may not recognize a lot of these faces because we're proud to have all these new hires in the past couple of years in this area. This is kind of been spearheaded by Dr. Tim Begleiter and I to kind of take the different aspects of psychiatric genetics that have been growing in our department and continue to build on that. And I've kind of posted some of the pictures of some of our recent team members here, which hopefully everyone in the department will get to know soon. But just to mention, one of the largest consortia in our field is called the Psychiatric Genomics Consortium. And I'm proud to say that at Downstate, we actually have leadership represented on our faculty in all of the major psychiatric genomics groups internationally. And this is exciting because not only are our faculty publishing in JAMA and Science constantly on this work, but we're also being contacted by really talented young people in our field, trying to find out what's going on at Downstate and wanting to work in our department. So really exciting for the future of our group. I also just want to mention that Dr. Begleiter, along with other investigators in our department, are working. This is in a partnership that was started by Dr. Ayman Fanous when he was here on the Million Veterans Program. And I have a couple of slides highlighting some of Dr. Begleiter's work on psychosis that I'm just going to, as Dr. McAfee said earlier, let you all do a lot of reading while I skim over. But just to mention, that Tim is doing incredible work through the VA and bringing a lot of our new faculty along board to work on this. Speaking of which, we have Dr. Peter Barr, who originally was trained as a social epidemiologist and works in our department, and he's an amazing data scientist that has expertise in studying things like suicidal behaviors, PTSD, as well as other mental health conditions. And I don't have the citation here, but just, he's in the past month published in JAMA and the American Journal of Psychiatry, and just constantly blowing us away by his amazing skills and work that he's doing. Dr. Zoe Neal is a clinical psychologist who just joined our group, who has expertise in working in dementia as well as genomics. And here's some of her latest work that hopefully she can give us a grand rounds on soon. And Dr. Chris Chatsinakos, who also just joined our group and is an expert in sort of bioinformatics and data science, and we're also very excited to have him on board. Also to mention that one of the passions that we've heard described here this morning is sort of this global emphasis in our department. Dr. Begleiter just submitted a grant and got an amazing score, putting together a team looking at mental health, both here in Brooklyn as well as in Trinidad, and just trying to bring this sort of global vision of looking at mental health worldwide forward. So again, bragging on my colleagues here, they all have a number of R01s from different agencies in the NIH, including the NIMH, NIDA, and NIAAA. And just to kind of reflect on a moment here, looking at all of the NIH funding, and this doesn't include the other types of funding that our faculty members here have, but we represent 52% of the NIH funding in the psychiatry department at Downstate. So I think it's a lot for us to be proud of. And moving forward, we're really excited about a new award that we got from New York State to put together a center that essentially combines the work that I presented here today with other areas of medicine to study mental health and community mental health, especially across the lifespan. So really integrating expertise, from early in life to later in life to understand how to, promote health and wellness in our patients. So with that, I'd just like to thank you all for listening and congratulate Dr. Viz one more time on his presidency. Thanks.
Ooh, there's lots happening. Thank you, Jackie. Our next presentation, and this will be the final one before our break, is by Dr. Michael Reinhardt. And I wanted to tell you a little bit about him. He's already been referred to in earlier talks, but he's an assistant professor, clinical advisory dean. He's the director of the Geriatric Psychiatry Fellowship, the director of the Brooklyn Initiative to Develop Geriatric Education, and the Center of Excellence for Alzheimer's Disease. He's going to talk about advancing the mental health of the elderly through service, education, and research. Okay, Michael, thank you.
So, pleasure to be here and to be introduced by my training director. For those of you that didn't know or hadn't talked to me about it, I'm former resident and fellow of Downstate. And I think what we've seen happening this year is something that I've known since I was a resident, and certainly now as a faculty member these past 9 years. We're being recognized on the national stage across multiple venues that we are excellent. Congratulations, Dr. Vis. And it was a pleasure to see one of my faculty mentors as a resident on the stage at the APA speaking so eloquently and with such passion about his experiences and about his vision, while simultaneously being introduced by my training director. That was just like the coolest moment. So it's so great to see all of the young faces here, and I hope that you're excited about all of the things that we're doing. And I understand that I have the relatively unauspicious position of being standing between you and a snack. So I'm going to do my best to be relatively focused and talk about our programming. So no conflicts of interest, no off-label treatment, because I'm not talking about treatment. And of course, I always acknowledge all of the funding that we have from the federal government, the Health Resources and Services Administration, and also the New York State Department of Health. I'm going to talk a bit about our division, and most particularly today, I'm going to talk about our two big funded programs, Bridge and SEAD, and then talk a bit about future directions because we have some cool stuff cooking. But I think I would be doing a poor job today if I didn't start by recognizing our mentor and distinguished service professor, Carl Cohen, the founding director of the Division of Geriatric Psychiatry. Carl founded our division in the 1980s and was responsible for training well over 100 fellows in geriatric psychiatry, which by my count is about 7.5% of practicing geriatric psychiatrists. That's pretty amazing. In addition to having well over 50 funded grant programs, hundreds of publications, and being nationally recognized as one of the founding fathers of our field. And so we were very fortunate to have him, and we miss him greatly. And so I'm going to just briefly do something that I think is important, and I'm going to do it quickly, just to emphasize why we've constructed our programming the way we have. For those of you that had forgotten, our population is aging, and it's going to keep aging, right? As we just heard from Dr. Myers, all of our colleagues in basic science and research, translational research, are also recognizing this, and we have to recognize this in the clinical space as well and make sure that our healthcare workforce is prepared for this. And just as important to understand that the overall population is aging is that the population of older adults is not distributed evenly. You'll see that New York is one of those places where there is a slightly higher prevalence of older adults living in our surrounds. And many older adults are not living above at income levels that we would like to see them at to support themselves as they move towards retirement. And the number of older adults living in poverty is most particularly notable for those of underserved backgrounds and those of minority backgrounds. And then if you take a look at Brooklyn, right, you'll understand that there are certain areas in which there are higher numbers of older adults. We are sitting in one of them. And some of the others are in service areas that you all treat as residents and physicians, right? Our partners at South Brooklyn Health as well are also noted on this slide. And these same regions, right, you might notice are also population centers for minority persons, right? So there's more Black, Hispanic, Asian folks living in population centers that we serve as residents. This is not a surprise to you, but I want to emphasize that we have an aging population of minority individuals that simultaneously are living in underserved areas. We don't have enough providers, right, serving these populations for reasons that are more than I can go into today. And so if you drill this down, right, into what this looks like in Brooklyn versus one of the very particular populations we serve, there's a remarkable public health burden that we are currently facing, that of Alzheimer's disease, and something that's only going to grow in the future. We currently have about 55,000 persons, this is an estimate, suffering from Alzheimer's disease here in Brooklyn, about 110,000 family and other caregivers caring for these people. And as the population ages, this is only going to increase. And the effects of this are going to be disparately experienced by older adults living in Brooklyn who have less income than other older adults living around New York City who don't have access to providers. And while this is all going on, we have a shortage of providers, right? There are less and less geriatric medicine specialists, less and less geriatric psychiatry specialists. I say that geriatric psychiatrists are kind of like medical unicorns. If you meet one, it's probably the last time in your career you're ever going to see one. And it's sort of true, we're on the decline, and this is all happening at the same time as there's been a 45 increase in demand for geriatric services, a number that's only going to go up. So that has all been put out there to say that our division has been very thoughtful in developing three main pillars of how we want to approach aging in our community. We want to make sure that in our clinical services, we're providing evidence-based, person-centered, and age-friendly healthcare. So high-quality healthcare that matches with what matters to people. Making sure that we're engaging with our community and providing education, because the providers are never going to be able to do it on their own, right? We have to make sure that older adults are empowered to ask for high-quality care, and then we have to be teaching everybody how to be providing geriatrics education or geriatric age-friendly care to our population across professions. So we have two big programs that have kind of been built out with this in mind. We have our Center of Excellence for Alzheimer's Disease at SUNY Downstate. This is now an 11-year funded program. We're in year 7. This is a program funded by the New York State Department of Health. We're one of 10 centers in New York State. We're one of 3 here in New York City. The other 2 are at Columbia and NYU. I think we're all very proud that we stand amongst other giants here in New York City providing this care. And we have an extensive array of partnerships with the really important goal of providing comprehensive, person-centered Alzheimer's disease and dementia care to all of New York City's residents. We're not just charged with serving Brooklyn, we're charged with serving all 5 boroughs. And to do this, we've put together a comprehensive team. Many of our residents and students have already been in my center. We've done our best to build out a team that not only is comprehensive in its interprofessional nature, but also includes members that represent our community. We have 4 social workers, previously 5 providers, currently 4 MDs and a nurse practitioner. We have PCAs, research support technicians, and additional clinical supports around the city. And we've also developed satellite centers. I run a satellite at South Brooklyn Health, and now have preceptorship-based satellite centers at Kings County Hospital over in the E building. Really fun. And also with one of our federally qualified health center partners in Brownsville, the Brownsville Multi-Service Family Health Center. So we are everywhere in providing care. The other initiative that I'm really proud of, and it's centered on our 3 pillars, is the Brooklyn Initiative to Develop Geriatrics Education. We are now in the 5th year of this program. This is a multi-million-dollar program funded by HRSA, with the stated goal of permanently and sustainably transforming healthcare and the workforce here in Brooklyn to be age and dementia friendly. And to do this, we've partnered with all of Downstate's colleges and schools. We've partnered with our really important institutional and educational partner, Kings County, New York City Health and Hospitals, Kings County, federally qualified health centers, and other community-based organizations to run a really comprehensive slate of programming that's focused on the age-friendly health systems initiative. helping all primary care providers, other providers, and our learners understand what matters to older adults, understanding the importance of judicious use of medications and deprescribing, the importance of mental health, and diagnosing and adequately treating dementias as they're incident in individuals, and of course delirium, and the importance of mobility. And so in combination, this is sort of an overlay of what this program looks like. We run really comprehensive interprofessional clinical care and education in our Center of Excellence for Alzheimer's Disease. We outreach to primary care providers all around the borough through our ECHO program, Extension for Community Healthcare Outcomes. We run really comprehensive community education engagement programming with our partners, the Fort Greene Council, on-site primary care preceptorship. We've developed an advanced certificate in public health geriatrics that's happening right here in this building with our public health faculty, and are in development of a care management program in our School of Health Professions, in addition to other primary care education initiatives at our partners' sites to help them attain age-friendly health system status. And so we have some really cool outcomes in that regard. So our own Center of Excellence here at here at Downstate has attained Level 2 age-friendly status. University Hospital has attained Level 1 age-friendly status. New York City Health and Hospitals, Kings County Ambulatory Care has attained Level 1 age-friendly status, and as has our partner Brownsville. Both of those other primary care partner sites are moving towards Level 2 status, which is a higher level of recognition and involves more rigorous data collection and quality improvement over time, are in progress for this spring. Really cool. And beyond like these cool outcomes, and I'll also talk about our data relatively quickly so you can have your snack, is that patient experiences have improved and provider experiences have improved as we've changed how healthcare is being delivered. Patients like being asked what matters to them. It's sort of surprising and heartbreaking how few patients have ever been asked what matters to them in their healthcare. And when you talk to them about this, they've been very grateful for it. And it has impacted care. And just as important, especially after the pandemic was a very difficult time for geriatricians. It was a difficult time for all of us. Providers also find this meaningful. They find the shift in practice to improve the quality of their interactions with their patients, and they find that they feel less burned out at the end of the day, something we're hoping to do a little bit of study of. So we've served a lot of patients, and we've done a lot of outreach. I think this may be the part where I can move quickly, where I try to impress you with my numbers, but also say that we're very busy and really working hard to achieve our goals. We do a lot of outreach to community dwelling elders. Every year these numbers have gone up. We've crested over 2,000 participants in our outreach sessions for this year for the Bridge program, and about 1,500 in our Center of Excellence for Alzheimer's Disease outreach programs. We reach predominantly minority individuals. We're hitting the population that we're reaching the population that we want to reach to improve outcomes. And not only are we reaching the population we had hoped to reach, most of our respondents, most of the participants find that we've done a good job when we survey them on their educational experience. We've reached a whole lot of trainees here at Downstate. These are not entirely unduplicated numbers. We do have some students that come back to us for multiple experiences, but still, a lot of folks have been reached through our educational programming across the different programs that we offer, including our webinar series. And this is the total number as of February of this year for the number of older adults that we've reached for our outreach programming. Really proud of the work that our team's done. As you all know, at Downstate, even with the funding that has allowed me to have a bigger team, our teams are still tight-knit and relatively small compared to some other institutions. So to be able to reach these numbers really speaks to the dedication of our interprofessional team across the colleges and schools at Downstate. It's been pretty cool. And this is the number of primary care and other learners that we've reached for ECHO, as well as our attendance numbers for our partner site at Brownsville Multi-Service Family Health Center, where we've helped their system to convert to an age-friendly health system. And county as well. And so just as maybe more important than the numbers is the fact that we've actually changed care. The rates of fall risk screening have improved. The rates of advanced care planning have improved. The rates of high-risk medication prescriptions have dropped. Our partners have increased fall risk screening by over 8-fold. Partner screening for opioid risk has increased to 100%. And there's more and more of these changes to healthcare quality measurements that are coming online as we wrap up this 5th year of funding. And so that's what we've been doing, and then we're kind of trying to leap towards the future. So we just recently submitted a new application for the Bridge program, and I'm really excited about some of the things that are coming our way. We are going to be developing, assuming I'm funded, I should be hearing any minute now, any day now. We're going to be developing in a similar idea to our partners at Kings County Hospital in the R building, a primary care service called WAVE, in which we're going to be integrating primary care into our Alzheimer's and geriatric psychiatry services to provide primary care services on site to older adults that have Alzheimer's disease and late life mental health concerns. We're developing new educational opportunities for our learners here at Downstate, as well as our primary care partners. And we've expanded the number of partners that we're having for this new application, including expanding to the U.S. Virgin Islands and to Puerto Rico to make sure that we're serving all of Area 2, other areas where we have remarkably underserved populations that mirror our own in very important ways. Really cool. And the Center of Excellence for Alzheimer's Disease over these next few years is working to develop additional satellite programs at in other areas around the city where we have higher populations of older adults in underserved settings, including in the Bronx, out in Far Rockaway. Not traditionally thought of as an underserved setting, but there's an important component of underserved population in Chinatown in southern Manhattan, and also in Staten Island, where they have a really, I think, well-run federally qualified health center that could use some extra help with their aging population. Pretty cool. And so we are also working on some cool research programming. I realized today that I should be talking more with my colleague, Dr. Myers. I think that's a nice outcome from this session for me. We have a fun partnership that's starting up with the University of Albany, linking clinical practice with some new technologies for the early diagnosis of Alzheimer's disease. That's a partnership that just started up in the past month. We're currently in discussion with another university, the details that I'll provide after the partnership has been fully fomented, to hopefully form a joint Alzheimer's disease research center. Really important initiative that'll bring some exciting research opportunity to Downstate and to our patient population here, in addition to all of our learners. And this new center will be focused predominantly on populations which have been traditionally underrepresented in Alzheimer's disease research. We also have some cool work happening with the SUNY Center for AI and Mental Health, of which I'm joining as soon as I can finish with some of the current projects I have going on. And we're in talks with some companies to start clinical trials here. So, thank you.
Thank you very much, Micah. So we're going to take a 15-minute break.